Alrighty, so our lecture today is going to be over esophageal disorders. This module is going to go by really quickly, although we have to cover a lot of information. Try to start from the head downward and then kind of work our way to the other organ systems like the liver and the gallbladder and things like that. But first is first, we're going to start with the esophagus. And when we are looking at our instructional objectives, here we have 10 objectives that'll try to guide you through this lecture. It is quite a long lecture, 78 slides, although there are quite a few picture-based slides and things. I'm going to try my best to hit the high points, although we all know that I tend to talk too much. I'll try my best moving through this lecture. Looking at the outline, we're going to start with esophagitis. We're going to talk about some infectious causes as well as non-infectious. Then we're going to move into some of the motility disorders, then into some mechanical obstructions and other lesions within the esophagus. And finally, we'll end with neoplasms. So I'm going to try my best to get through this, and let's get going. To start off, we have to talk first about some of the common chief complaints when we talk about the esophagus. Now, if you've watched my intro lecture, you'll have already kind of touched on some of these common chief complaints and kind of how they present. But just as a review, heartburn. What is heartburn? I think most of us have experienced some form of heartburn in our lives. It literally feels like burning within our chest, or kind of radiating up from the kind of middle of our chest up to our neck. It's usually caused by acid reflux, and it's highly suggestive of GERD. Now, when we talk about GERD, we will talk more extensively about gastroesophageal reflux when we get to the stomach lecture, although we know that the reflux goes up into the esophagus. Now, dyspepsia, which we'll also cover in the stomach lecture, is kind of this burning pain, discomfort, bloating, nausea, belching. It's kind of the Pepto-Bismol, that commercial where it's like, heartburn, indigestion, upset stomach. That's kind of what I think of when I think of dyspepsia. Bloating, it's usually after eating, and a little bit of nausea, some belching, heartburn associated. So it's kind of this word we give indigestion. Odynophagia is painful swallowing, plus or minus some substernal chest pain. And it can be a discomfort. It can be related to something up in the oropharynx, the throat, like a throat infection, all the way down to problems within the esophagus itself. It can be due to like ulcerations like herpes, esophagitis, erosive esophagitis from, say, acid reflux, and other things. It's painful though. When we get down to dysphagia is simply difficulty swallowing. And different patients describe it different ways. They can describe it as a sticking, a strangling, a choking sensation, but it should never be associated, the word dysphagia should never be associated with painful swallowing, although those with dysphagia can also have pain. Dysphagia itself does not mean pain with swallowing. It means difficulty swallowing. And as I mentioned, patients kind of can go all over the place with describing dysphagia. It can be all the way up from the throat area, all the way down to kind of the mid-chest, almost upper abdominal area, where they can feel this sense of difficulty. When we break down the word dysphagia, we're going to kind of try to break it up into two separate things. One, oropharyngeal dysphagia, which happens in the mouth and in the oropharynx, has to do with preparing the food for swallowing and kind of the mechanism associated with that. And then we're also going to talk about more at length, of course, is esophageal dysphagia, which is dysphagia at any point in the upper to lower esophagus, in the body of the esophagus, essentially. And so initially we talk about oropharyngeal dysphagia. We're talking about prepping, this phase of prepping the food to be swallowed. And I don't know if you've ever really considered it or thought about it, but it's quite a process that we take for granted when we talk about, preparing food, chewing it, breaking it down, and passing it into the esophagus and not getting it into our airway, which is directly in front of our esophagus. And so patients that have problems in the oral phase of swallowing tend to have spillage from the mouth. They have this uncoordinated effort to chew and initiate swallowing. Sometimes they have dry mouth. Pharyngeal dysphagia is usually these patients have this sensation of the food kind of sticking or catching at the back of the neck, and they have to kind of like swallow repeatedly to try to clear the food from their pharynx, and they tend to choke. So they have a lot of coughing, choking fits while they're eating. And when I think about oropharyngeal dysphagia, I associate it more with things related to neurologic problems or structural problems, upper motility problems, but usually more neurologic stuff. So like previous strokes, Parkinson's, Huntington's, things like that. That's how I tend to think of it. So we won't necessarily discuss oropharyngeal dysphagia too much. Now, one thing that we will talk about is Zenker's Diverticulum. We will touch on that. So, and also pill-induced, things like that. But for the most part, we won't touch on most of these because they are more neurological in nature. Esophageal dysphagia is what we're going to be focusing on most often today. And this dysphagia is caused by one of two major mechanisms. The first being mechanical obstructions. So mechanical obstructions means something is in that tube, that long tube that is our esophagus. Something is blocking it at some point along the way. Food has a nice cylindrical passageway through the esophagus to go from our mouth down to our stomach. But in certain cases, we have these obstructions. And as you can see here in the chart from your book, mechanical obstructions include rings, strictures, cancer, and esophagitis. There are also problems with motility. So we know that as the food passes from our mouth to our oropharynx and into our esophagus, then the esophagus does this kind of dance where it kind of gently squeezes the food down into the stomach. It's a passive thing that we don't really ever think about. It's smooth muscle. But that process is also a coordinated effort. And there can be problems with that motility, that moving the food downward. It can either be a problem with dysmotility, where it's not coordinating its effort properly, or it can even be that there's too much motility or too much tightening of the muscles, as in achalasia. So we'll talk about these a little more at depth. One of the major things that differentiates them when we talk historically speaking is with mechanical obstruction. Most patients tend to have primarily solid food problems, so problems passing solids, whereas motility disorders tend to have both solids and liquids. So these will be important things you'll want to ask your patient or identify in a vignette when we're discussing dysphagia. And the reason for that is, well, if you have a mechanical obstruction, say like a cancer or a mass, it tends to be kind of in one part of the esophagus. It doesn't completely surround the esophagus like a motility disorder. So motility disorder will affect the entire muscle and tighten the esophagus, so neither solids nor liquids pass. But if you can imagine a tumor kind of obstructing part of it, the liquid can kind of trickle past it up until it becomes so large that it obstructs the entire esophagus. Then we probably have problems with both. We'll talk about this a little more in depth as we tackle each of these different dysphagia disorders. So we're going to start with esophagitis. So esophagitis is what it says it is. So esophagus is esophagitis, inflammation, infection. And so there are multiple different causes for esophagitis. I love this picture. It kind of it's kind of heartburning, but also just inflammation of the esophagus. We're going to start with infectious. Okay, infectious is most commonly caused by Candida. Candida is yeast, like a yeast infection or like a thrush in the mouth. We notice these infectious esophagitis most commonly in immunosuppressed patients. So we're talking about patients with AIDS, solid organ transplants, leukemia, lymphoma, those receiving immunosuppressive drugs. And then even so in uncontrolled diabetes, we even see this in uncontrolled diabetes. We also can see some of these in patients that are taking systemic corticosteroids or that are receiving radiation therapy or even systemic antibiotic use. So I don't know if any of you watch Paul Bolin videos. He actually had strep throat, took an antibiotic, and developed candidal esophagitis from that. So just things to think about when we're examining patients and considering infectious esophagitis. So like I mentioned before, Candida albicans by far the most common type of infectious esophagitis. It is caused by yeast. We also consider herpes simplex, HSV, and CMV, cytomegalovirus, as common pathogens. But all of these, most of them, I'll say, are occurring in patients that are immunocompromised. They just go hand in hand, okay? So most of the time in a vignette, you're going to see an HIV patient or an uncontrolled diabetic, something like that is going to pop up. In contrast to infectious types of esophagitis, we also have non-infectious types of esophagitis. The most common is going to be reflux esophagitis. So this is essentially when gastroesophageal reflux, or GERD, has this acid that's continuously spilling up out of the stomach and into the esophagus, and it can actually start eroding and causing changes in the esophagus and inflame the esophagus. So that is reflux esophagitis, which we'll touch on a bit more in our stomach lecture. We also have other non-infectious causes such as medication-induced or pill-induced esophagitis and eosinophilic esophagitis, which we'll go into one by one. So here's our infectious esophagitis. What do we usually see? Well, painful swallowing, odynophagia, and difficulty swallowing are the top two symptoms that we'll see. Depending on how far down the infection goes, if it extends the length of the esophagus, you can also get some substernal or retrosternal chest pain. And in a lot of cases, especially with Candida, actually have no symptoms. It can be asymptomatic. Specifically with Candida, we also tend to see oral thrush, and there's a nice picture of that here. Oral thrush is this kind of carpet or blanket of white material that forms on the inside of the buccal mucosa and the tongue. And if you try to scratch this off with, let's say, a tongue depressor, you'll get bleeding. It'll be able to scrape off, but you'll get a little bit of bleeding beneath it. And oral thrush is present in about 75% of patients with candidal esophagitis. So just because they don't have any lesions in the mouth doesn't mean that they can't have them in just the esophageal area. And also patients with viral esophagitis, such as herpes simplex, only 25 to 50% of those have other indicators of the disease, such as herpes labialis, where you get this kind of a cold sore on the lip. So you can't always rely on what you can see to help you identify what you can't see. But here's a nice image of herpes labialis, which can be associated with herpes simplex esophagitis. How do we evaluate these patients? Well, treatment can be empiric. Let's say we have a patient, we know they have a little bit of odynophagia, and we look in their mouth and we see thrush. We can treat them empirically. We don't necessarily have to do an evaluation. Although if needed, especially in a patient that we don't know to be immunocompromised, we're going to want to do an endoscopy with biopsy and brushings for analysis. It's very accurate. When we do this endoscopy now, we've kind of talked about it briefly in the intro lecture, but when we say endoscopy, we mean an EGD or an upper scope. It's a camera. We go in, we put the patient to sleep, we go up in through the mouth, the camera, and we evaluate the E in the esophagus, the G, the gastric area, and the D, the duodenum. So that's EGD or upper endoscopy with biopsy. That's what we mean when we talk about that's a camera. We look and we take samples. And so that's going to be what we do for an infectious esophagitis. I can distinctly recall a patient when I was in PA school. I was doing my internal medicine rotation at Scott & White in Temple, Texas, And we had a young man, he was a construction worker, young white gentleman, in his mid-20s or early 20s. They came in with trouble swallowing and painful swallowing. And we looked at the back of his throat and his mouth. We couldn't see anything, but he was having pretty difficult time swallowing. He had also lost weight. And so they ended up doing an evaluation on him, and they found that he had candidal esophagitis. Now, this guy didn't have any history of being immunocompromised, but on further evaluation and further questioning, it turns out that this guy was actually homosexual. He had not come out, and it was kind of a closeted homosexual who had developed HIV and AIDS and didn't know it, and had developed esophagitis, candidal esophagitis. So it was all these unknowns that came to light just because of the odynophagia that we kind of did as we investigated the cause. So don't always assume in the real world that just because you don't see HIV next to their name or anything like that, that they don't have that underlying. You should always be suspicious, especially if they have a quote-unquote normal history, okay? So looking at some of these pictures, I think pictures, they say 1,000 words, right? This is candidal esophagitis. These two images down here, you'll see that white kind of yeasty, thick, kind of creamy plaques. And, it can be, like I said, in the mouth. It's called oral thrush. You can have candidal rashes kind of from the mouth to the butt. You can get diaper dermatitis that's caused by candida. But if we see candida, we should be thinking some sort of immunocompromised or recent antibiotic use, something like that. Herpes esophagitis looks a little bit different. Usually we tend to see, just like herpes on the skin, see these erosions or little crater-like things in the mouth or in the oropharynx and in the esophagus. They're little erosions or ulcers, and sometimes in the healing process get this kind of whitish lesion that's umbilicated, so it has like a little umbilicus or a little clearing in the middle. Right? So how do we treat them? Well, we have to identify the cause of the infectious esophagitis before we decide how we're going to treat them, because the treatment is different for each one. For candidal esophagitis, which we said was the most common infectious esophagitis, systemic therapy is required. And when we say systemic therapy, usually it's an empiric trial of antifungal therapy. And sometimes, or in certain cases, we don't always have to do the endoscopy and make the diagnosis. If we see the candida, we know they're immunocompromised, we can treat them empirically. The initial therapy of choice is going to be fluconazole. Patients that don't respond to this, if we haven't already done an endoscopy, we should do them to differentiate them from other types of infections. And there is other treatments we can use, such as itraconazole or the voriconazole. And a refractory treatment can also be treated with this capsofungin, although that's getting a little bit too pharmacological. Generally speaking, when we have this question come up, you talk about fluconazole. Now, the only difference to this would be in a small baby, especially with oral thrush. A lot of times we'll use nystatin, troches and things. But when we have esophagitis in the esophagus, we start with fluconazole. Okay? Talking about herpes. So usually herpes is self-limited. It is a virus. So it's not really a treatment that we do. It doesn't cure it, but it helps reduce the length and severity of symptoms. Patients that are immunocompetent that have this, they don't always require specific antiviral therapy. But if we make the diagnosis and we want to treat, usually acyclovir is our first line. It is the least expensive, although it is 5 times a day. So if we're concerned that a patient is non-compliant or won't take the medication, we might choose to start with a different medication like one of these two, because it's less often that you take it, although they are more expensive than acyclovir. We also have kind of a second line, kind of a backup for non-responders, which is a Foscarnet IV. CMV is also a virus. We usually use, we have to get the patient, especially in HIV, we have to get them back on their antiretroviral therapy. We got to get their CD4 count back up to help control CMV, help prevent it from happening. But with treating CMV on its own is ganciclovir. is the one we're going to be using for that. There are other treatments for CMV, but that's the first line therapy, and that's the one that I'd like for you to remember. Moving on to the non-infectious esophagitis. So reflux esophagitis is the most common type of esophagitis. This is not infectious, obviously, but it's caused by GERD. So we'll cover GERD more in depth in their stomach lecture. But essentially what happens is the lower esophageal sphincter, the kind of sphincter or gateway between the stomach and the esophagus, tends to be loose. And so we get spillage of stomach acid up out of the stomach and into the esophagus, which, if you can imagine an acid in an area that's not supposed to withstand acid in the esophagus, it doesn't have the cells that help us prevent or protect from the stomach acid up in the esophagus. So you get this inflammation due to GERD. And eventually, over time, that recurrent exposure to the stomach acid can cause other problems like stricture formation, Barrett's esophagus, which we will talk about at the end of this lecture, and other things like Schottky rings. So primary symptoms, heartburn. It can also present with dysphagia, dinophagia, cough, chest pain. I've seen patients come in thinking they're having a heart attack and they just have GERD. So it can be pretty bad. Of course, there are things that predispose patients to having GERD, being overweight, drinking lots of caffeine and other things can put you at higher risk for that. So GERD is super common. I bet if I polled all of us, there's probably quite a few of us that do have GERD, but it's not always required that we have an upper endoscopy or an EGD to diagnose GERD. However, if we're thinking that the patient has had long-standing GERD, that we need to look for Barrett's, or if they have evidence of erosive esophagitis, then we need to go ahead and do the upper endoscopy. And I'll talk a little bit more about screening for Barrett's later on. We want to get these patients comfortable, okay? If they have erosive esophagitis on their EGD, meaning that there is visible erosion because of the GERD, then we're going to want to start the patient on PPIs initially. PPIs are proton pump inhibitors. So that we can get that level of acid down and help get rid of that erosive esophagitis. And then we can taper them down to a comfortable level. This is usually taken on by a gastroenterologist if it gets to this point. Basic GERD can be handled by primary care. Once we get up into the erosive esophagitis, then we should probably be managed by gastroenterology. So pill-induced or medication-induced esophagitis is what it says it is. So patients take medications, right? I bet all of us have taken a pill in our life, hopefully. Or maybe not hopefully, but all of us have taken a pill before. We put the pill in our mouth, we pick up whatever water ball is laying by the bed, and we take a sip, and we let it go down, right? Well, not always, right? So sometimes larger pills, or patients that take pills without water, patients that lie down right after taking a pill, the pill can actually get stuck in the esophagus. And if certain pills get stuck that are caustic, such as like an NSAID or other medications, you can actually get erosion and inflammation of the esophagus in that area. And it's really due to just direct prolonged mucosal contact, right? The most common type of pill that causes this is NSAIDs, although there's many other types that can cause it, including potassium. Potassium pills are pretty big, like horse pills, Other things that I tend to see in vignettes a lot are the medications like alendronate for osteoporosis, vitamin C, and then certain antibiotics like Doxy. Doxy tends to cause synclinda. And usually this happens because patients take their pills without water, or they lay down when they take it, or also patients that are hospitalized or bedbound are at higher risk for this. And patients typically present with this severe retrosternal chest pain, kind of where that pill's sitting on their esophagus, and it usually happens shortly after taking the pill. And The thing about it is the older you get, the more likelihood that you're going to be taking medication is. And the elderly, for some reason, just don't have the same pain response that we do as younger folks. So a lot of times they won't really complain of pain, more they'll present with dysphagia over time. Endoscopy, your camera goes down there, usually reveals kind of these discrete ulcers due to where the pill goes. And here's one. They're like these little shallow ulcers in one little area. And I mean, it can get pretty bad. If you have chronic, the pill's sitting in the same place every time, you can get pretty severe esophagitis. You can get hemorrhage and even perforation. Once you get rid of the insulting cause, so if you teach the patient how to take their pill or you switch to liquid medication, then the esophagitis should heal. And whenever we tell our patients to take their pills, we should always tell them to take it with at least 4 ounces of water and remain upright for 30 minutes after ingestion. That's a good rule of thumb. Here's an image. This is actually a patient that had a clindamycin-induced esophagitis. You can see there's like a discrete, sharply defined erosion right here. And that's where the pill literally was sitting right there. And then you also have some other kind of these like sliding ulcerations, as you can see, as the pill's kind of sliding down. You get it at the esophagus as well. So this is pretty striking when you see that. One other thing I want to mention is if you know your patient has an esophageal dysmotility or dysphagia or problem, stricture, you need to be very mindful of these medications, especially the offending agents, these right here. These medications, you need to be very cautious when prescribing those medications to patients with known esophageal dysmotility or dysphagia. Last but not least, for esophagitis, we're going to talk briefly about eosinophilic esophagitis, or EOE. Eosinophilic esophagitis is probably less well known than all the other ones we've discussed. But essentially what it is, we think of eosinophilia, we think of allergic response, inflammatory response. And it's usually recognized in kids, at least initially. And it's actually predominantly seen in men. Usually these patients have a history of atopy. So they have asthma, eczema, hay fever, allergies. And these patients tend to present with dysphagia, as well as food impactions, chest pain, and GERD-like symptoms. And some of them that I've seen in the GI clinic present with this vague kind of upper abdominal pain, and it's related to what they eat. So this patient would tell me, I don't know, every time I eat avocado, I get this really severe abdominal pain in the upper area. And so you kind of have to put the pieces together historically. And then the evaluation is done with endoscopy with biopsy. And we take the histological evaluation, helps establish the diagnosis. You'll see this eosinophil predominant inflammation. So when we take the biopsy, we send it to pathology, and they see lots and lots of eosinophils. And that is indicative of esophagitis. Other things that we tend to see with eosinophilic esophagitis are these rings. So it's pretty characteristic, these little rings. That's not normal on the esophagus. So seeing these rings and these little white spots tend to also help the gastroenterologist think it could be EOE, although the diagnosis is essentially made with the biopsy. We also, in the evaluation of EOE, we do skin allergy testing, and that helps the patient identify triggers or foods that they are allergic to that can provoke this type of reaction. The treatment of choice for this, we tend to give them PPIs, proton pump inhibitors. This will be like your Nexium, things like that. And that helps reduce the amount of acid production, helps kind of keep the environment more conducive to less pain and inflammation. And then we tend to do topical glucocorticoids like, fluticasone and things like that you would spray. You actually spray it in the mouth and they swallow it. In severe cases, you can also use oral corticosteroids temporarily to get the inflammation down. And then the other major treatment is going to be eliminating the things that they're allergic to by food allergy testing. motility disorders. So we're going to go into some of the motility disorders. Here's kind of an at a glance of the ones that they tend to talk about in textbooks and on your tests. Achalasia, by far most common type of motility disorder that we tend to see. We're going to talk at length about achalasia. We're also going to talk about DES, or diffuse esophageal spasms. We are not going to go into the others though. So neurogenic dysphagia, that's more a neurological issue that's caused by injury at the brainstem, cranial nerves, problems with dysmotility of the esophagus due to those things. Scleroderma esophagitis is an autoimmune disease, so you will cover scleroderma in your rheumatological module. So we're not going to cover it here, but essentially you get decreased sphincter tone. So the opposite of achalasia, where you have a lot of gastric contents kind of splashing up and causing dysphagia. Esophageal stenosis, we're really not going to talk about much. And then Zenker Diverticulum is not really a motility disorder, but we will talk about that in a little bit. So let's talk about achalasia. Achalasia is an acquired motor disorder of the esophagus smooth muscle, in which the lower esophageal sphincter, or the LES, fails to completely relax with swallowing. So remember we talked about the esophagus. I like to think of the esophagus kind of like a tube of Go-Gurt. I don't know if you've ever eaten Go-Gurt before, but if you think about how you get the yogurt out of the Go-Gurt tube, it has to be kind of a coordinated squeeze of the yogurt up or down, right? And so that's kind of how the smooth muscles in your esophagus work, right? So they squeeze in a coordinated effort to get the food kind of going downward. And that also requires that certain parts of the esophagus relax to allow that bolus of food or liquid to go down. Now, in achalasia, the lower esophageal sphincter, so the point where the esophagus meets the stomach, this LES, it doesn't relax. The muscle is always super tight, really, really tight. And so because it can't relax, the food and liquid cannot pass past that point. So you get dilation of the distal esophagus, the esophagus just proximal to the lower esophageal sphincter, and you get this tightening here. So if you can imagine, neither solids or liquids have an easy time passing through here and into the stomach. So there are some subtypes. I don't necessarily think that you need to know that for the pants, but just for completeness sake in this lecture, achalasia has 3 subtypes. The first 2 subtypes are non-spastic, and the third is highly spastic. And really the only reason why that matters is how you treat it. But we'll talk about that a little bit later. So it's idiopathic. We don't really know what causes it. We do see it in the United States. Adenocarcinoma is the second most common cause of achalasia. There is an association between achalasia and cancer. So we'll talk about that as well. In the world, not just in the United States, Chagas disease is actually a really important cause of achalasia, or an achalasia type problem with dysmotility. And if you've never heard of Chagas, go ahead and Google it. It's literally the stuff of nightmares. So Chagas disease is the kissing bug disease. So essentially while you sleep at night, you think you're just relaxing in Latin America, right? It's usually in Latin American countries. And this nasty bug, the kissing bug, kisses your eye, because that's usually where it tends to bite you, around the eye area. And you wake up, you have this bug bite that becomes swollen, and then the disease, the toxin, spreads throughout your body and causes long-term problems, including achalasia type problems with the esophagus. It also causes enlarged heart and things like that. It's just bad news. It's not a good thing to have, but it's something to remember, because not all achalasia is going to be idiopathic, because we live pretty south in the United States. So there's a chance that we can have someone with the Chagas disease that's presenting similar to an achalasia type picture. So how do they present? Dysphagia is by far the most common presentation, so just trouble swallowing. And I mean, this is it's progressive. So it kind of gradually starts. They start having trouble with dysphagia, but it's equal with solids and liquids because remember, it's tightening down the whole way. That's different from other things like esophageal cancer where solids start first and then liquids later. These patients, they tend to eat really, really slowly, and they have to drink water to try to wash the food to get the food to go down with it. And you can actually see that they kind of take a bite, they eat it, and then they have to stand up, kind of twist their body, extend their neck, walk around to try to get the food to pass. It's really uncomfortable. Then you have to kind of teach the patients how to eat properly. Food gets stuck, so it gets stuck in the distal esophagus, and then when it can't pass, a lot of times they will actually get regurgitation of food, and with that comes the risk of aspiration and problems with like lung abscesses and things. Some patients do also experience some substernal chest pain. About 50% of the patients do, as well as weight loss because of inability to eat. They have trouble eating. And like I mentioned, they can have recurrent pulmonary complication because of aspiration. So how do we diagnose it? Well, if we happened to get a chest radiograph, I wouldn't say that is by any means the best test to do, but on chest radiograph, sometimes you'll see an air fluid level with the fluid-filled esophagus. Because remember, we drink and eat, it gets to the point where there's the most constriction at the lower esophageal sphincter, and then it kind of dilates above that. This is normal, and this is obviously abnormal. The classic presentation is by barium swallow, which is a radiologic imaging where you have the patient drink this barium in contrast. It goes down, and we take images by fluoroscopy or x-ray to see where the contrast goes. And you'll notice here what the bird's beak. And I had trouble when I was first like, where's the bird's beak? I don't see it. But this is a really interesting Google search that I did. And so you can kind of see this looks like a bird's beak. And that's where the food or liquid is just trickling through that tight area. Other things that we do are upper GI endoscopy. And that's really to rule out other things like carcinoma, cancer. Because achalasia is bad, but cancer's worse. So we have to do the EGD to help rule out cancer. And then if we're talking about gold standard meaning the best, most confirmatory test to diagnose, it would be manometry, esophageal manometry. And that is when you put a monitor down into the esophagus and into the LES, and it takes pressure, so readings of pressure. And that will make the confirmation. Not all patients that you consider having achalasia have to have the manometry. There is a process for diagnosing. So you suspect it, dysphagia, heartburn that's not responsive. You do the upper endoscopy. Generally speaking, we do the upper endoscopy first because we have to rule out the cancer before we can blame it on something else like achalasia. We get the upper endoscopy. If we notice some of these things, then if we do not notice that there's retained food or resistance of passage of the scope, then we can evaluate for other things. Okay. If we see those things on endoscopy and we don't find cancer, then we do the esophageal manometry, and that'll help confirm the diagnosis. Okay, so this is really specific. This is like GI office stuff, but essentially I'm just trying to show you kind of how you move from one step to the other. I think with GI, a lot of the times it's like, well, what do I do first? I don't know what to do first. And if you just try to think through logically, it'll help. And as you notice, there's a barium swallow here that we do. Sometimes the barium swallow gets done sooner. Sometimes it gets done before even the endoscopy, although that is controversial. Nowadays, we tend to do the endoscopy before the barium, but back in the day, we used to do the barium before the endoscopy. So anyways, there's a lot of different ways to evaluate patients with dysphagia and with suspected achalasia. I'm going to try my best to help you figure out what the tests are and when we use them. I will say, after working in GI office, we tend to do the upper endoscopy first for these cases. So patients with achalasia have a 7-fold increase in developing esophageal cancer. It can be squamous or adenocarcinoma, but they do have a higher risk, okay? So we do have to be mindful of that. And a lot of times these tumors can go unnoticed because the esophagus is so dilated above that, and the patients are chronically ill. So these patients do require surveillance to look for tumors since they are at higher risk. And the good thing is that many times these patients tend to get dilations or pneumonic dilations, where you go in with a balloon and kind of dilate. And while you're doing that, you can also take a look for signs of cancer. So I love these little videos. They were passed down to me. But I'm going to show you a normal, these are barium swallows. I'm going to show you a normal barium swallow. Let's see. So the patient drinks the barium. And there they go. The barium is going to go down, 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 down. And we watch it kind of just gently float down. And you see it kind of just gently glides down. There's a little kind of bottleneck effect here, but it goes down pretty smoothly, and that's normal. Now let's look at the achalasia. Should notice a major difference. So we skipped the whole part of the oropharynx, but we do see down at the distal esophagus, here's the LES. There's essentially nothing passing. You get a little bit of bird beaking, a little bit of passing, but you can see it gets dilated and backed up all the way up. And that's definitely not good. How do we treat achalasia? Well, we said it was idiopathic. We don't really know what causes it, and there is no cure for it. All the treatments that we do, including surgery, are just palliative. Now, I will say this. Medical therapy is not good for achalasia. There really isn't good, effective therapy for this. We do tell the patients to chew their food to the consistency of pea soup. We have to do soft diets to sleep with their trunk elevated, avoid eating before they sleep. So there are things that we can recommend. There are some medications we can give, like antimuscarinics and nitroglycerin, calcium channel blockers, nitrates, but they're not that good for achalasia. Generally speaking, we have to do something about it. And there are several things that we can do. One thing that we can do is injecting Botox, essentially, at the LES. And that helps in about 65% of cases, although it tends to have to be repeated at least every 2 years. Before we do Botox, generally what we do first is a dilation. Usually it's pneumatic, which is a balloon. We when we do the endoscopy, we have to do it anyway. We go down there, we can do the balloon, we get it, we inflate the balloon where the stricture is at, and that dilates that area. And there is some risk of perforation, about 3%, and it tends to be less and less effective as we have to repeat it, but it's usually kind of first line for patients with achalasia to have this dilation done. Now, after a few times of dilation or Botox and things just aren't getting better, we can do some surgical treatment. There are really two major surgical treatments. The classic surgical treatment is what we term the Heller myotomy or the Heller cardiomyotomy. And essentially what that is we go down and we incise the muscular layer of the lower esophageal sphincter, and that releases some of the tightness there and allows food and liquid to pass into the stomach. This is generally done laparoscopically, and a lot of times at the same time they go ahead and do a fundoplication, which is where because you can imagine if you cut that muscle, then they're going to have reflux because now they don't have any muscle tone at the lower esophageal sphincter. So they tend to do at the same time a fundoplication, which is where they kind of create a bit of a sphincter, and I'll show you a picture of that. It's actually really good. Up to 90% of patients are good. And the good thing is that even after you have this myotomy, if you tend to have symptoms, let's say maybe 10 years down the road or within the next 10 years, it's very responsive to pneumatic dilation after you go back in there. So that's a good thing. One of the newer types of surgical treatments is POEM, or per-oral endoscopic myotomy. And this is essentially like a Heller myotomy, but instead of being laparoscopic, it's less invasive. It's endoscopic, so you can do it with an endoscopy. And you make the same kind of little incision. It's surgery, but it's endoscopic surgery. The only thing with this one is that you cannot do the fundoplication at the same time because it's not laparoscopic surgery. And so these patients tend to have chronic GERD and have to be on proton pump inhibitors. And remember we talked about the different subtypes, so there's 3 subtypes of achalasia. Well, type 3, the spastic type, responds best to POEM. And that's really the only reason why I mention it. Really deciding on the optimal treatment is going to depend on the patient's age, whether they're able to tolerate surgery at all, and then, whether or not there's a concern for post-treatment GERD. So this is something that the gastroenterologist and the specialty surgeon would discuss. Just generally speaking, to review the different treatments, medication, no good for achalasia. We can try it, but it doesn't work well. Generally, we tend to start with pneumatic dilation, plus or minus Botox. And then once that stops working, or if it doesn't work, then we move on to surgery. And really, that's just at the discretion of the patient, whether they can tolerate it or not. And then just knowing that there's 2 different types. Okay. All right. So this is the endoscopic dilation, or the balloon dilation. We find that point of achalasia. We go down and we inflate the balloon, leave it inflated for a period of time, and then we uninflate it, take it out, and it stays dilated. Here's your Botox injection. At the end of your endoscope, you have a place where you can inject Botox, and that relaxes the muscle. Here's your Heller myotomy. So Heller myotomy, remember, is laparoscopic. So you go in laparoscopically, you make an incision through the muscle, and that way it releases some of the muscle tension here at the LES. And remember, that would also then make you more prone to having GERD. So a lot of times with the Heller myotomy, we have a fundoplication along with it. There's 3 different types of fundoplications. The Nissen fundoplication is this one here, where you take the stomach and the fundus of the stomach and you wrap it around and sew it together to create kind of a sphincter. Although this one can cause some of the same problems that you had already with achalasia, so they tend to do either the toupee or the door fundoplication with a Heller myotomy. And last but not least is the POEM. And here's a little image of how they do that. They take the endoscope. Remember, it's done all endoscopically. They kind of create this little submucosal tunnel, and then they clip it, so it kind of removes that muscle in that area. So those are different treatments for achalasia. Moving on to DES. So DES, diffuse esophageal spasm, is a spontaneous contraction of the esophageal body, and it's like in several different segments. It's all just spasming at the same time, and it because of this kind of spasticity and this lack of coordination, it prevents food and things from being passed down. And a lot of times these patients, the sphincter, the LES, it has normal pressure. It's more throughout the body, although you can have some trouble with the LES as well with the ES. These patients present more with chest pain, and it can mimic angina, except that it's not only on exertion. It's kind of retrosternal, and it can even radiate to the arms back. And so in this case, anytime you have a patient that you think has DES, they need a cardiac workup as well. It's not generally related to eating, which makes it more kind of difficult to diagnose, and dysphagia is also common with it. However, regurgitation is uncommon, and the dysphagia can be provoked by stress, large food boluses, hot or cold liquids, or at rest. And so these patients must undergo cardiac workup. And if they're at the right age with the right risk factors, they might even need a cardiac catheterization before you can blame it on DES. So I don't know if any of you have ever seen The Holiday. It's a Christmas movie. I think of Cameron Diaz. She gets throughout the movie, especially in stressful situations, these esophageal kind of spasms. And that's what I think of when I think of DES. The evaluation, usually we do, you can do a barium, but if the patient's not having the spasm at that time, you're not going to see anything. The classic finding for the upper GI or the barium swallow is going to be a corkscrew esophagus, which is what we saw here. It looks kind of like a corkscrew. And that's due to the different sections of the body of the esophagus contracting simultaneously in a spastic fashion. Upper endoscopy we do to exclude other things like mechanical obstructions, cancer, erosive esophagitis, and eosinophilic esophagitis. So the upper endoscopy is not to diagnose the DES, but to rule out other things that are that it could be present. And then again, just like with achalasia, manometry is the gold standard, although it's not routinely used for mild to moderate symptoms because they don't really change the management in this case. Okay, like I mentioned, all patients should have a complete cardiac workup. And treatment, in contrast to achalasia, where in achalasia meds didn't really do much, in DES medication is the mainstay of treatment. That's what we start with for these patients. Of course, just like achalasia, we're going to have patients eat more slowly, take smaller bites. Sometimes we can even encourage them to drink some liquid at the start of a meal to kind of facilitate the swallowing, kind of calm down the esophagus before we get it going. We also tend to place these patients on PPIs to see if it helps with their symptoms. In regard to diffuse esophageal spasm, usually we give a combination of these medications empirically: smooth muscle relaxants, calcium channel blockers, phosphodiesterase inhibitors, and sometimes Botox or POEM at the later stages. Also, it's not as common to do dilation, but sometimes you can get relief. The problem with these is that there is no really completely effective therapy. You get a lot of failure rates, a lot of recurrence. So these patients do have to be on medication off and on long term. Here's some more pictures of that corkscrew esophagus. And then this is pretty good video of the same thing. So you can kind of see it. And we can remember what we saw in the normal one. It's not as striking as what we see in the pictures, but we can definitely see it. All right. So I think right here would be a great time to take a little break, especially if you're getting fatigued. I know it's been a long lecture so far. We still have about halfway to go. So this would be a good time to take a break. So if you need to take a break, and then come right back. right, so next up, we're going to be doing other esophageal lesions, kind of mechanical obstruction. Remember we talked about the two major causes of esophageal dysphagia were either motility disorders or mechanical obstructions. Well, we talked about motility disorders. Now we're going to talk about some mechanical obstructions and other lesions. And we're going to start off with one of the grossest ones, okay? So a Zenker Diverticulum is the most common cause of diverticula. Diverticula is essentially a little outpouching where it doesn't belong. And it tends to happen in the upper third of the esophagus. And in the posterior oropharynx, you have these cricopharyngeal muscles. And they don't relax when you're swallowing, and it increases the pressure there. I don't know if you've ever tried to blow up a balloon where you're like blowing, and all of a sudden, whoosh, the balloon inflates. And so that it's once that pressure threshold overpasses, then you get that outpouching. So you get essentially this little outpouch, this separate little pouch at the back of the oropharynx between the cricopharyngeal muscles. It becomes an area of weakness, and you get this little pouch. It doesn't belong there. And if you can imagine, it can cause dysphagia. You can get food particles and things stuck in that little pouch. And if it gets stuck there for long enough, it essentially rots in the back of your throat, and you get this horrible halitosis, bad breath. And then because of it, you can also get weight loss, chronic cough. And in really, really severe cases, you can actually even see protrusions in the neck itself. Because you have all this undigested material at the back of the throat, you can also have aspiration pneumonia, lung abscesses, and things. So the best way to diagnose it is by barium swallow. And we usually do that under video esophagography. And that's where you're looking at the barium as it's going down, kind of in live video, kind of what we've been seeing. Treatment is surgery. So symptomatic patients require a myotomy, where they kind of cut the pouch out and sew the muscle back together. And this is improvement for patients. And let's see. Here's some pictures. So you can see there's your constrictor muscles at the back of your throat. And this outpouching that forms this little pouch back there. When we swallow our food, some of the food goes down the esophagus and some of it collects. And if it collects there for long enough, we get this nasty rotting of food and this horrible bad breath. Here's the barium. And here's a video. Okay, you can see it right there. So some of the liquid goes down here and some fills up in the Zenker Diverticulum. It's pretty gross, but it's easy to diagnose on vignettes because they always mention something about halitosis. All right, moving on. Esophageal stricture. So stricture, just like a stricture anywhere else, is a narrowing. Okay, and so stricture can be from thickening of the wall of the esophagus, and that can be for multiple different reasons. Sometimes they refer to it as stenosis. Benign strictures are usually due to GERD, so that acid that keeps splashing up causes kind of this narrowing of the walls, scarring and narrowing of the walls. You can also get it from eosinophilic esophagitis or caustic ingestions, like let's say you tried to commit suicide by drinking bleach or things like that. You can have problems with strictures because of that. Other causes of strictures are like cancers. They cause stricturing or narrowing, but it's usually less uniform. Next we're going to talk about esophageal webs and rings, which are kind of like versions of strictures, but they kind of have their own thing going on, so we're going to talk about them individually. So esophageal webs are these thin little membranes that occur usually in the mid to upper esophagus, and you can have multiple of them within the esophagus. They can be congenital. You can also get them with eosinophilic esophagitis and other things. And we tend to see them with this Plummer-Vinson Syndrome, which I will talk about in a little bit. Esophageal rings or Schottky rings are these smooth circumferential, like a ring, thin, and they tend to happen in the distal esophagus, and they are associated with hiatal hernias. We also tend to see them a lot with reflux, and so it's thought that GERD has something to do with how they form. Most webs and rings are over 20 millimeters in diameter and are asymptomatic. You really don't start seeing problems with dysphagia, especially solid food dysphagia, until about 13 millimeters in diameter. And usually it's intermittent and non-progressive. So, for instance, you're eating a steak at a steakhouse, you don't chew it enough and it gets stuck. And usually what they do is they'll kind of drink more liquids and kind of try to get it to come back up or to pass through. Sometimes they actually have to have it removed endoscopically, and then at that point they know that they have it, and they try to prevent it from happening again. They're best visualized with the barium esophagram. You can also do endoscopy, but you can't see them as well in all cases. And treatment-wise, you can treat them with in the balloon dilator. Is usually how you do. You can also have surgical incision of the ring. And like I said, most patients are asymptomatic, so you don't really need to do anything about them. But others do actually have to have these things done. And usually, especially with like Schottky rings, you really have to keep their acid content down because that will help them from recurring. So here's a picture of the two. The one on the left here is circumferential. So the problem is all the way around the lumen of the esophagus. And then here we see it's only in one part of it. So this is a ring and this is a web. And that's how I think of it. The web kind of looks like a spider web hanging off one corner of the esophagus, whereas this ring is the whole ring. Okay. Now, we mentioned this syndrome called Plummer-Vinson Syndrome. And Plummer-Vinson Syndrome is associated with upper esophageal webs plus iron deficiency anemia and all of the things that come with it, including glossitis and cheilitis. And they also get this spoon-shaped fingernails. And they have these esophageal webs, okay? They get dysphagia. So the way that osmosis mentions is that plumbers die. So I think of Mario. I'm a huge fan of Nintendo. And I think of die, dysphagia, iron deficiency anemia, and esophageal webs. And that's Plummer, our Super Mario Plummer-Vinson Syndrome. And so if you see those together, that's what they're trying to tell you. Now, Schottky rings, we said, are lower down than webs, and they are associated with hiatal hernias. And you can see those are Schottky rings. You can see them really well on barium swallows. I think this is a good barium image for you. Still waiting for it. Oh, there it is. Right there. Hopefully you can see it. It was at the distal esophagus, right? Because we said it's usually right by the lower esophageal sphincter. You can see that one kind of circumferential narrowing. So we mentioned that Schottky rings are tightly associated with hiatal hernias. Now, what is a hiatal hernia? So hiatal hernia is when part of the stomach comes up in past the diaphragm where it doesn't belong. Now, characteristically, there are two major types of hiatal hernias. One is the sliding type, which is when everything just kind of slides up where it doesn't belong. And two is the periesophageal type, and that's kind of when the part of the stomach comes up through the hole in the diaphragm. But the gastroesophageal junction does not. So it remains below. And I'll show you some pictures of that. By far, the sliding hiatal hernia type 1 is the most common. And a lot of people have small hiatal hernias that don't even know that they have it. I have one. I didn't know I had it till I had an EGD done. So it's benign in most cases, but it is associated with GERD, with gastroesophageal reflux. In the type 2 hiatal hernia, it is slightly more prone to strangulation, so sometimes these do have to be repaired surgically. So here's some barium images. I don't think they're as clear as the images I have on the next picture, but they do show the different types. There's also some mixed types, but for all intents and purposes, types 1 and 2 are the ones we want to know, and we will talk about them a little bit more in the stomach lecture. Like I said, most of them asymptomatic. They're found incidentally, but you can also have symptoms typical of GERD, so heartburn, some chest pain, dysphagia, and you can get some reflux esophagitis and Schottky rings associated with it. Let's see. A diagnosis: barium, upper GI series, and upper endoscopy tend to show it. And then treatment, I mean, most of the time for type 1s, you just kind of have to treat the GERD. If it becomes to where you can't get the GERD under control even with medications, then you have to have a Nissen fundoplication to tighten up the lower esophageal sphincter area and keep the hernia from sliding up and into the thoracic cavity. Type 2 hernias are generally treated with elective surgery because of the risk of herniation and strangulation. So here's a better diagram of the different types of hiatal hernias. Here's normal. This is the lower esophageal sphincter lies right at the area where the diaphragm meets. And type 1, everything kind of just slides up, so it's a sliding hernia. And then type 2 is where the lower esophageal sphincter stays below the level of the diaphragm, but the stomach kind of comes up, perisophageal. And then types 3 and 4 are also kind of these mixed types where you have some sliding and you have some protrusion of the stomach. Moving on. So Mallory-Weiss Tear. Mallory-Weiss Tear, I tend to think of it as kind of like a paper cut in the esophagus. I don't know if that's a good analogy or not. It's kind of what I think of. It's this non-penetrating, so it's a mucosal tear. It doesn't go all the way through, but it causes bleeding. So it's like a little cut causes bleeding, and it usually comes from a sudden raise in the transabdominal pressure, such as like lifting something heavy or retching, having vomiting spells, or repeated episodes of vomiting, like say in an alcoholic or bulimic type patient. And clinical features: it's responsible for about 5% of upper GI bleeds, which we do have a lecture on bleeding, so we'll cover this and other things at more length. Most commonly, especially in vignettes, they associate it with binge drinking, alcoholics, or bulimics, people that are constantly drinking and throwing up, right? Hematemesis is the hallmark symptom. It can be just a few streaks of blood to massive bright red bleeding, and this is with or without melena or dark brown bloody stools, depending on how much you're bleeding. Now, we do have to distinguish Mallory-Weiss from Boerhaave syndrome, which is a complete esophageal rupture. Remember that the Mallory-Weiss tear is not transluminal, doesn't go all the way through the esophagus. How do we diagnose it? Well, in some cases, especially in the right clinical picture with minimal bleeding, You can diagnose it clinically. However, the diagnostic test of choice is an upper endoscopy, so a camera to go in there and look for it. And once they're in there, they can elect to inject it, say with epinephrine, or cauterize the bleeding if it is significant enough. I would say that in most cases, 90% the bleeding stops spontaneously without any treatment. Although any patient that is bleeding, having GI bleeding, whether from up top or down below, the first thing you should do is always assess the patient for resuscitation efforts. So fluid resuscitation, blood transfusions, and the like. Because whereas someone is bleeding, sometimes it can take a while for the bleeding to affect the patient, to affect their vital signs, to affect their hemoglobin and hematocrit. So the most important thing you would do is always start with fluid resuscitation and start evaluating the patient before you start jumping to conclusions. Usually after the fact, after we know that they have it, we put them on acid suppression like a PPI to help promote healing of the cut. Okay, so here's some pictures of these little, like I said, little paper cut looking things. And here's a distinction, my favorite mid-comic distinction between Mallory-Weiss syndrome and Boerhaave syndrome. So Mallory-Weiss, little tears, hematemesis, see as an alcoholic. It's caused usually upper GI bleed only, sometimes melena, but rarely. And it's incomplete. It only affects the mucosa and some mucosa. Whereas Boerhaave's this is a true emergency. So you have a complete rupture of the esophagus, and because of that, you get chest pain, and patients have shock, low blood pressure, high pulse, and Hayman sign, which is this crunching sound when you're listening to the heart. And that's because air is in the esophagus and goes into the mediastinal area, and you get subcutaneous emphysema, which is essentially like air under the skin. It can kind of like pop it like those little like bubble wrap under the skin. And so this is not good. This is what you're looking for. And if you got a chest x-ray and something like this, you'd see air in the mediastinum, and the patient tends to look very, very ill. We have to diagnose this. Mallory-Weiss, 90% spontaneously get better on their own. Boerhaave's, we have to do something about it. Esophageal varices, we're going to cover very, very briefly because we are going to cover this more in depth in the GI bleed lecture as well as in the cirrhosis lecture. But just because it takes place in the esophagus, I feel like we do need to mention it here in the esophageal lecture. So dilated veins in the esophagus the veins become dilated because there's an elevated pressure in the portal venous system. And the most common cause of portal hypertension and increased pressure in the portal venous system is from cirrhosis. Okay? There's also other things like Budd-Chiari and other things that can cause it, but by far cirrhosis is going to be your number one cause. This can be very much life-threatening. Esophageal varices you can bleed out very rapidly. So there is a process of screening and surveillance for varices, which I'm not going to go into right now, but essentially any patient that you have that has cirrhosis should undergo testing and evaluation to look for esophageal varices. These are the things that you want to catch before they start bleeding and cause death. So about 50% of patients with cirrhosis have esophageal varices, and bleeding from these varices happens in about 30% of these patients. And in the absence of any treatment, variceal bleeding spontaneously stops in about 50% of patients. However, patients that survive this bleeding episode have up to a 60% chance of recurrent variceal bleeding within the next 6 weeks. And it's associated with a high morbidity mortality rate of up to 15%. So this is something that if the patient has cirrhosis, you do have to screen them and do surveillance for esophageal varices, because it can be a pretty high mortality rate if the patient has bleeding varices. And so we will talk about this more later on. Just for thoroughness sake, here's a nice little picture of varices. They kind of look like varicose veins, like the kind you see in legs. but in the esophagus, because they are varices, right? They're engorged veins. And it happens because the liver becomes cirrhotic. The blood is not able to pass through the liver, so it takes all these bypasses, all these extra routes, like the frontage roads around the liver. And one of those frontage roads around the liver is this esophageal plexus, and so they get engorged and they can tend to erode through and bleed. All right. Let's talk briefly about esophageal foreign bodies. So these are pretty, I don't know how that's possible to swallow a spoon, but this is way more common, coins and things. We talked about tracheal foreign bodies in the pull module. Now we're talking about esophageal foreign bodies. So kids don't always tell you that they've swallowed something that they're not supposed to. So with little kids, a lot of times what we'll see is the inability to swallow without regurgitation. Hopefully you can recall the story I told in the pull module. I told a story about a baby that I saw for vomiting in the ER that I did a chest x-ray on, and I found a coin in their esophagus. And the baby essentially would drink anything and it would come right back up because there was blockage in the esophagus. Patients also can't swallow their own saliva, so they tend to drool. And the vomiting is pretty immediately after they drink. Now, not all patients are pediatrics. Sometimes we have patients that come in that have, let's say, dentures and can't chew well, and they're having a steak dinner and they get a large piece of meat that gets stuck. I've seen that a lot in the emergency room. And a lot of these patients have history, like, every time I try to eat steak, it gets stuck. Those are the adults. But kids, they swallow everything. And really what you have to be mindful of is it big enough to obstruct? Is it getting past the stomach? Or is it something sharp, pokey, or caustic like a battery? Diagnosis is made by x-ray or clinically, usually x-ray. And depending on the size, the shape, how far it's passed, if it's something simple like a small coin and it's made it past the stomach, then we just watch and look out for the coin in the poop. However, if it's lodged in the esophagus, if it is not past the stomach, or if it's sharp or caustic like a button battery, those need to be removed urgently. Coin ingestions, that's what I see most common. Kids just love eating coins for some reason. Like I said, if it's past the stomach, there's really no treatment. If it's stuck in the esophagus, it's not going anywhere. It needs to be removed endoscopically. Button battery ingestion, I cannot stress this enough. Button batteries are in everything. All these little devices that we have button batteries in them, and kids somehow open these up and they can be true emergencies. They can actually perforate through your esophagus or through the stomach within 4 hours, and that can be detrimental to the child. You always have to go in and remove them. Okay. Remember to consider esophageal versus tracheal foreign body. If it's in the trachea, the patient's going to have trouble breathing, audible sounds, whereas the foreign body in the esophagus is going to be more trouble with swallowing. All right, last but not least, let's talk about cancer. So esophageal neoplasms, there are really two major pathologic types. So we're not going to get too much into the pathology, but we do need to know that there are two major types. The first is squamous cell carcinoma, and this is accounted to up to 90% of cases worldwide. It is the most common type of esophageal cancer worldwide. Okay. However, in the United States, the incidence of adenocarcinoma has increased dramatically and accounts up to 50% of new cases. And it's important to know the difference between them because they present a little differently. They have different risk factors and different populations that they tend to happen in. So for squamous cell carcinoma, the incidence is higher in African American men than in other groups. It is most common in the upper and mid-thoracic esophagus. That is definitely where it's more common. Risk factors for this include alcohol, tobacco use, certain diets that are low in fruits and vegetables, HPV, achalasia, and Plummer-Vinson syndrome that we talked about. History of caustic ingestion, like we said, accidentally drinking bleach or maybe on purpose drinking bleach, and also associated with other nasopharyngeal carcinomas. The distal 2/3 of the esophagus, it says that it's more common there, but the most common locations I've found are the upper to mid esophagus. That's where I tend to see it more. For adenocarcinoma, it's more common in Caucasians and in men. Remember, we're talking about more common also in the United States. It's way more common in the distal third, so close to the gastroesophageal junction, and it makes sense because the major risk factor for adenocarcinoma is GERD, uncontrolled GERD, and Barrett's esophagus. Alcohol and tobacco are not as important as in squamous cell carcinoma, but they can also affect or play a role. GERD by far is the most common risk factor, and we'll talk a little bit about how it goes from GERD to Barrett esophagus. Oh, one other thing I wanted to mention that I forgot is one of the other risk factors for developing squamous cell carcinoma, and maybe why it's more common like in Asian countries, is drinking hot liquids. So like patients that drink tea on a regular basis, hot tea, have a higher risk of squamous cell carcinoma, which I thought was really interesting. The prognosis for esophageal neoplasms is poor, and that's mainly because it's usually pretty advanced by the time it causes enough symptoms to be detected. It says 5-year survival rate about 30-40%, but only 5% if there's distant metastases at the diagnosis. And they use a TNM system, which I'm not going to get into too much depth on, but it's a tumor, node, and metastases. Okay. Clinical features. So dysphagia is the most common symptom, usually because it's a mechanical obstruction. It usually causes only solid food dysphagia, and as the tumor or mass grows, it then progresses to liquids. We also see significant weight loss associated with these cancers. One, because it's causing some obstruction and trouble with eating, and also because it's the cancer itself, you get some problems, you get anorexia. It can cause some odynophagia, but it's usually a very late finding. It can also erode and cause some bleeding, hoarse voice, depending on where it is exactly, and you can get some of these other things associated. Diagnosis. Barium swallow is useful in evaluation of dysphagia, and you can make a presumptive diagnosis of a mass on that, but by far the diagnostic test of choice for cancer is going to be an upper endoscopy with biopsy, and this confirms about 95% of the cases. Once we have a diagnosis, we will send the biopsy off to see whether it is in fact cancer or dysplasia, and from there it will determine whether or not how we treat it. And so they also get a lot of times a transesophageal ultrasound to look for penetration, staging, and also a full metastatic workup including CTs, chest x-rays, PET scans, looking for cancer in other places. Therapy or treatment, really you have to decide whether or not there is curable or incurable disease. We use the staging system to help determine this. For disease that is stage 0, 1, or 2A, can have surgery plus or minus chemoradiation, and those that have pretty significant tumor obstruction will require this kind of palliative effort to help them while the tumor is shrinking, so they'll have to get like a gastric or a J-tube. Most of the time, I would say the majority of the time, palliation is the goal, because by the time the disease is detected, it's advanced at presentation. Can't do surgery on these, and primary goal is really just to relieve symptoms, improve the dysphagia pain, and optimize the quality of life while minimizing side effects of treatment. So sometimes these patients get some palliative chemo to reduce the size of the tumor, or they can get stents placed in the esophagus to help keep it open, to help them be more comfortable as their disease progresses. So here, close to the lower esophageal sphincter, we have adenocarcinoma, and here a little bit higher up, we have squamous cell carcinoma. Now, we mentioned that a precursor to adenocarcinoma is Barrett's esophagus. And essentially what Barrett's esophagus is it's a complication of long-standing acid reflux, uncontrolled acid reflux. So in our stomach, we got these this columnar cells that are good at withstanding high acid contents, right? And what happens is that over a period of time, we get all this splashing of acid because of GERD up into the distal esophagus, right at the lower esophageal sphincter area. And those cells there at the base of the esophagus start changing. They start going through columnar metaplasia. So they start changing from the squamous epithelium to columnar, more like the stomach, and to withstand that high acid content. And because of that change in those cells and the replication of the cells, you have a risk of developing dysplasia of the cells and hence adenocarcinoma. And so these patients have monitoring with endoscopic surveillance and even screening for this. So they say that anyone that's had long-standing GERD, especially uncontrolled GERD, anywhere from 5 to 10 years should be screened for Barrett's. At the GI clinic that I worked at, my gastroenterologist was a bit more aggressive, and anyone that was coming in that had 2 years or more of GERD had a screening EGD. How we treat it, when we find it, depending on whether or not there's any dysplasia, then we do a lot of PPIs trying to get the acid reflux down. If we have cells that we can burn off, we do radiofrequency ablation, and then we do endoscopic surveillance. And that's looking for, it's like a surveillance system, right? So you know that it's there, or know that it's been there, and you're looking for it. So how do we screen? Like I said, in my GI practice, it was 2 years or more. But here's some of the risk factors for adenocarcinoma in addition to GERD. So hiatal hernia, age over 50, male gender, GERD, chronic GERD, white race, central obesity, cigarette smoking, and a confirmed history of Barrett's in a first-degree relative. And so as you see the progression, Barrett's esophagus is the precursor to precancerous changes, so dysplasia and then eventually cancer. And so we want to be able to catch it at this phase and prevent it from progressing to full-blown cancer. And so given these risk factors, we'll do a screening endoscopy with biopsy, and if we do find Barrett's esophagus, then from then it's surveillance. Here is an algorithm from UpToDate for surveillance of Barrett's esophagus. It can be kind of complicated. You got to look at all these different factors involved, and this is taken into account by the patient's gastroenterologist. All right, I'm not going to go into depth with this here. You actually have 50-fold increase in developing adenocarcinoma with Barrett's. That's why it's so important to continue surveilling these patients. So we've essentially done dysphagia. We've done the esophagus, and we talked initially about taking the medical history and differentiating between oropharyngeal dysphagia and esophageal dysphagia. Oropharyngeal dysphagia is going to require a different workup. Esophageal dysphagia, we're going to then look at some of the history. Is it more solids or solids and liquids? If it's solids only, then chances are it's more than likely a mechanical obstruction. Is it intermittent or progressive? And that'll help us to determine whether we think it's more of a stricture, carcinoma, ring. But essentially, this is all just educated guessing. We'd have to go in and take a look and do the testing, which the next page, our next slide, will talk about. If we notice that difficulty with solids and liquids, it's more than likely a motility problem. If it's intermittent and it has chest pain associated, it's more than likely DES. If it's progressive and has to do with regurgitation and weight loss, and we see bird beaking and things, and it's achalasia. If we have chronic heartburn, GERD, and problems with rheumatologic disease, and likely scleroderma. This is a nice summary to help us kind of wrap our brains around everything we've just talked about. And last but not least, this is UpToDate's version of the approach to diagnosis with a patient with esophageal dysphagia. And like we said, there's so many different tests to do, and when do we do them, and when do we do the EGD first, when do we get the barium swallow, what about the manometry? Oh, it can get overwhelming. So UpToDate really tried to break it down and make it a step-by-step process. So once we have the history of esophageal dysphagia, we're going to look at the patient history. We're going to look for prior radiation, caustic injury, surgery, esophageal cancer, or complex stricture. If they have had this before, then we can do a barium swallow first. However, this little asterisk here mentions that doing the barium swallow before the endoscopy is quite controversial. I would say the vast majority of the time in a GI clinic, we're going to do the procedures first. We're going to do the upper endoscopy first, plus or minus biopsies. Either way, this is what UpToDate says. After you do the endoscopy and biopsies, those are going to show you structural abnormalities. They're going to show you whether the patient has rings, webs, strictures, diverticulum, whether there's erosive esophagitis or some big tumor, or any other type of esophagitis. You're going to see that on camera with the EGD and with the biopsies. If we don't see anything on the endoscopy, then we need to do some more digging. If the dysphagia is to solids alone, which indicates more of a mechanical obstruction, then we're going to move on to the barium swallow if we didn't already do it. And then it might pick up something that we missed, such as a web or some other mechanical obstruction. If that's normal on this side, then we're going to manometry. However, if up here the EGD was normal, but the dysphagia is to solids and liquids, then, or we suspect a motility disorder, then we're going to skip the barium swallow if we haven't already and go to the esophageal manometry. And then from there, the manometry will help us differentiate whether it is motility or not. And again, if we haven't done the barium swallow at this point and we still have equivocal results, then we're going to do the barium swallow. So there's a lot of different approaches. They call it practicing medicine for a reason. There are some gold standard tests that we talked about, and overall endoscopy biopsy tends to be a gastroenterologist's go-to first test. One, because it rules out the bad stuff, and two, it's something that they can physically do. Gastroenterologists like to get in there and look with a camera because it's something that they do. They're not going to send you off to radiology to have it done. They're going to do it themselves, and so they can kind of rely on their technique and what they see and find. So that's what we're going to learn for today. I know it was a long lecture, and I do appreciate your dedication to sitting through it. It's just the start of the GI system. As you'll find, GI is fun because it's a lot of things that you can see, touch, feel, and evaluate with your eyes, which I think is really interesting. I loved GI when I did it, and it's really fun to get to go through it with y'all and teach you. So if you have any questions, feel free to reach out to me. If not, I'll see you next time.